Good evening. I'm really thrilled to be here. I wasn't quite sure who my audience would be, so I'm hopeful that when you leave this evening, you'll take home some of the enthusiasm that I'm feeling about the weeks to come, and that's because the oral arguments on the Affordable Care Act begin next Monday. This is quite an exciting time to be a lawyer, even a more exciting time to be a health lawyer. If you have any interest at all in constitutional law, there's some fundamental questions that the court is going to opine on about the powers that are vested in Congress and the powers that are vested in the states. So there's a little bit of something for everyone, whatever your interest is, if you're a United States citizen, or if you're not, if you're an observer from another country. It's a very interesting time to take a peek at how the law works in our country. Before I get started, I want to learn a little bit about you, so I'm going to ask for a show of hands, how many undergraduate students are here? Quite a lot. Thank you for coming. You could be somewhere else. I noticed there are quite a lot of bars around. You could have been there having a drink or a beer or something. How about graduate students? Wow, impressive. Professors. Constitutional law experts. I am so glad. Physicians. Any physicians? Glad to have you here. And I know a really fine financial person is here because I saw Ed Tucker come in and Ms. Barney Abear, who's my favorite lawyer in Mississippi. So some of what I'll discuss this evening is going to be very dry to you. I'll try to make it more practical when we hit those points, to try to tell you why it should be important to you, or maybe not so important to you, because there's so many residents in the United States. All of us who are U.S. citizens are impacted by the Affordable Care Act in one way or another. We are college students, and now because of the Affordable Care Act, we can stay on our parents' insurance till we're 26. Or we're children with pre-existing conditions, and now we can be covered because as of September 2010, pre-existing condition exclusion was not allowed for insurance plans. Or we work in a hospital and we know that money is tight because payments have been cut from the federal government, and that's going to continue for a while. So there's something in this bill for everyone to be concerned about, to be pleased about. I would dare say no one likes everything. It may be difficult for those of us who are honest to say we dislike everything. So we're going to get started. I'm a history major, so I always like to know how we got where we are. And this looks a little different, so I'm going to try this. So what got us here? You probably can't see that unless your eyes are a lot younger than mine. But this traces from 1970 to 2009, when the Hospital Insurance Trust Fund, that's what Medicare Part A, all the hospital payments rely on, that trust fund, when that goes bankrupt, when it becomes insolvent. And what frightened those in the legislature and the policy wonks, those of you who are studying health policy, was what the number looked like in 2009, which said by 2017, not too far away now, the trust fund is going to become insolvent. And what that told them was, we can't keep operating the way we are with the Medicare program. And they wanted some changes. Some of you may be old enough to remember the Clinton's health care plan, the Health Security Act, that came along in 1993. I want to ask for a show of hands on that one. It didn't get very far. And the Clintons used a different approach. It was sort of a behind closed doors approach, and no one saw it until it was sprung on us full blown. The Obama administration changed that approach, and we saw the sausage being made, and maybe that wasn't very pretty, but it was a different approach. Oh, and I don't like this sliding in, but we're going to do it. The increasing numbers of uninsured and underinsured and the looming baby boomers. And I think an important part to take away here is the number of adults who under age 65 who are either underinsured, which is 29 million, and 81 million either underinsured or uninsured. That is a lot of people approaching hospital emergency departments, unable to go to physician offices to get coverage because they lack, to get physician services or hospital services because they're uninsured. The Medicare enrollment. You've heard of the aging baby boomers. This is a very good indication. Look, from 1966 to 2010, how those numbers are increasing. And that, along with the looming insolvency of a hospital insurance trust fund, gave a lot of the legislators and the policy wonks concern. The increasing cost per capita of healthcare spending was going up and up. That was another concern. So, what happened, and we watched it, and it took a long, very long year and part of 2010. So throughout 2009 and part of 2010, we had the negotiations for and the actual enactment of two bills. As you'll recall, there was first the Patient Protection and Affordable Care Act, which is called PPACA in a lot of circles, and that was enacted on the 23rd of March in 2010. But that had to be reconciled because that was enacted by the House and it had to go to the Senate, and the Senate had to make changes, and it came back and went through reconciliation. So we're going to call it collectively the Affordable Care Act because it really is two separate bills that are cloned into one. And it's long. There are some people who've read it all. I am not one of them. And it costs a lot of money, and it's potentially supposed to save a good bit of money. And I'm going to tell you what it costs, and as you know, what is it, statistics, and damn statistics, pardon me. But initially, this bill was supposed to, well, if you'll recall, we were really worried that it was going to be $1 trillion. And so the bill came in just a little under $1 trillion. We have here $936 billion. But that didn't take into account the administrative costs, the implementation costs, which bumped it up to more than $1 trillion. In fact, it was 1.3, excuse me, that's not the right number. It was 115 billion of a discretionary spending, which bumped it up over $1 trillion. Recently, that's been amended, and it's going to be $1.131 trillion, which is a little bit less than the initial estimate. Move these all in. Here are the healthcare reform goals, and they look lofty. The first was to expand the coverage. We're going to talk about that because that's done in multiple ways. Enable more people to have access. Try to cover the majority of those that are uninsured, who are legal residents. Also to reform the private health insurance market. There are significant concerns that some persons were denied health care coverage because of pre-existing conditions, because of age, because of other health status. So some of those provisions were modified. To improve the quality of care, because the thought was and remains, if the quality is improved, the cost will go down. To bend the cost curve, to make health coverage less costly on a per capita basis, and to strengthen program integrity. When you see the words program integrity, think fraud and abuse, fighting, and different ways that the federal government now data mines to try to determine if some of the payments made to healthcare providers are not appropriately billed. So we're going to talk a little bit about, first of all, the individual mandate. And you might be surprised to know that the individual mandate, which is now, and I am very apolitical, I will tell you that, but it is certainly not a household word, favorite of the Republican Party, but it came out of a conservative think tank. And it was a concept that was devised to counter the Clinton health care plan. But, you know, times change and opinions change, so now it's sort of switched sides. But the concept of individual mandate is that each citizen should have minimum essential insurance coverage of some type, and they have to have it for not only for themselves but for their dependents by 2014, by January 1, 2014. If they don't, then they're going to be asked to make required to make a shared responsibility payment. That sounds a whole lot better than penalty, but that's what it is. It's a penalty. Some will argue it's a tax. The way it's collected is by the Internal Revenue Service through your tax payments every year due on April 15th. That is going to be up to roughly $700 by 2016, or it's a capped percentage of the household income for those paying taxes. There are waivers available. There are hardship waivers. There are religious waivers. There are waivers if you aren't even required to make tax payments. That is the individual mandate, and one of the ways to expand so that more of the residents of the United States will be covered. Now, it wasn't intended to cover quite everyone. The numbers that it's intended to cover, and I'll tell you in just a minute as soon as I can turn pages, I need about 4 hands, will cover an increased, the numbers of the uninsured will fall to 17%. So 17% of the residents of the United States will still be uninsured in 2010. So it's not full coverage of everyone, but the majority of those who live here will be covered. Now, another way that coverage will be provided is through state exchanges. Historically, it's been very difficult for individuals in small groups to obtain coverage that's affordable. So one of the concepts that was devised was to set up state exchanges. You'll be pleased to know that the Mississippi Health Insurance Exchange is in place and is working hard so that when it needs to start accepting insureds on January 1, 2014, it will be ready. These exchanges are going to be web-based. You'll go online to purchase your insurance coverage there if you qualify, and I will get to that in a minute. And there will be plans there that will provide essential health benefits. Now, that's a strange term. The concept is that it's going to be the type of coverage that most small employers have already. It's going to range in tiers, so as you would expect, the lowest tier, the lowest cost tier is not going to have quite as you'll have to pay more actually for that through some cost co-payments and deductibles. It may not cover as many benefits as something that costs a little bit more, but it will be available for those who are in smaller groups. Large groups at a later date will also be able to participate. And there's a catastrophic plan that will be included for individuals who are under 30 who can't otherwise afford that coverage. And if you're in an exchange, there are subsidies available. If you have income that's between 133% and 40% of the federal poverty level, which is quite low if you look at the bottom of the slide. You can't get a subsidy if you're eligible for governmental insurance. So if you're a Medicaid beneficiary or if you're a Medicare beneficiary, you won't be eligible for this subsidy. Or if you have insurance through your employer, unless the insurance costs more, the premiums cost more than 9.5% of your income, or it just doesn't cover enough to reach that 60% actuarial value, which means the cost of the benefits, health benefits you're really receiving through the policy. I told you this was going to get dry. We're sort of in the dry place right now, so bear with me. And also bear with me if I, do what I just did. What we don't hear talked about a lot when we get to the arguments that are going to be before the Supreme Court next week is the employer mandate. And this is a pay or play, or play or pay type of mandate. It applies to employers who have 50 or more employees full-time as of January 1, 2014. If those employers do not provide health insurance coverage, the minimum essential benefits, then they have to pay a penalty of $2,000 per FTE. They have to pay it if they don't offer the coverage, or if at least one of their employees, one FTE, gets a subsidy through the exchange-based coverage. There's also a penalty if the employer offers insurance coverage, but it's too expensive. the premium exceeds 9.8%. The penalties that an employer has to pay are not tax deductible. Now, that's not a good thing for employers. They like for their business expenses to be tax deductible. So this you've heard a large hue and cry from the employer community about the provisions of the Affordable Care Act with regard to this employer pay or play. And we'll talk about this more when we get to the arguments to the Supreme Court. And oops, there it goes. Another way to expand coverage so that more people have health insurance is through expanding the Medicaid rolls. What will happen, and upwards of 3.5 million, 350 to 400,000 additional Medicaid beneficiaries in the state of Mississippi will be covered, because Medicaid eligibility is going to be expanded to 133% of the federal poverty level. This all occurs January 1, 2014. And you see what this means, 133% of the federal poverty level in 2009. It's increased some by 2012. It is not that large a sum of money for an annual income. The way that this is going to be paid for, at least initially, is by the federal government. So the additional persons who are going to be covered by Medicaid, the federal government will pay for that increased coverage for those individuals. It will not, however, pay for the administrative cost. When you have 350,000 or 400,000 people becoming eligible for Medicaid, you have to enroll them in the program. So that a lot of administrative costs the states have to just absorb and pay for. This is a great concern in a state such as Mississippi, where we have a large number of persons on Medicaid rolls, and where we get, luckily, large transfer payments, 3 to 1, from the federal government for each $3, basically for each dollar that the state supplies. We get $3 from the federal government, and it will be higher when in 2014, unless something happens at the Supreme Court level. This will go forward. So this is of great concern to all the 50 states, and it's why they filed a lawsuit almost immediately after enactment of the Affordable Care Act. Now, these are some provisions that hit home to almost all of us. There were significant changes, and they're rolling in each year, but they started in September of 2010, and there were changes that were effective in January of 11 and January of 2012. And I'm going to list the main ones. There are too many for us to go through all of this in the short period of time that we're going to be here. But first is the guaranteed issue provision. And that basically says, as on January 1st, 2014, insurers have to cover anybody who applies for insurance. That is not the case today. Also, the community rating provision, effective the same day, says that your coverage and your premiums can't vary based upon your health history, your medical history, if you've had bypass surgery, if you've had cancer. And there are only small rate variations if you're a tobacco user or because of your age. Pre-existing conditions prohibition. I mentioned children under age 19 who were, in September of 2010, insurers had to cover those children regardless of whether they had a pre-existing condition. As of 2014, all coverage, no coverage can be denied because of a pre-existing condition. Health status discrimination, again, bars eligibility coverage rules based on health status factors. Do you have HIV? Do you have, that's also sort of a pre-existing condition too, or some genomic issue. These are important provisions that impact a large number of people, and if you have a family member, this may be part of it. So now we've gone through 2 of the goals. The first goal was to improve access to care. The second goal was to reform the insurance coverage provisions. And now we're on the third, which is to improve quality. There are a number of ways that, and I'm going to hurry through this, but there are a number of ways that quality is intended to be improved. Lots of different programs. I mentioned here the ACO program. Let's see if there's another one. This program is, through this program, groups of providers, hospitals, physicians, post-acute care providers such as skilled nursing facilities, home health, are able to form we'll call it a group, let's say an organization, and they are going to be required to treat a certain number of Medicare beneficiaries. This is for Medicare person. They're supposed to provide all the coverage that that Medicare beneficiary needs. And if they're able to save money based upon some benchmark, they'll determine here's the cost of providing care to this individual year one. If they're able to save money, the federal government will pay them some percentage of that savings. If they don't save money, and there are a couple of options, I'm not going to go into the details of this, if they don't save money, then the organization has to pay back. And the thought is by gathering the providers for a particular individual, they will be able to make collective judgments as to care and improve the health of each of those beneficiaries that are covered in the accountable care organizations. There's some healthcare providers that are enthusiastic about this. There are probably many, many more who are not enthusiastic about this concept. First of all, it's for a short period of time, 3 years. And secondly, it's very difficult to get all of those folks together in one room and agree to go along together. You have to have electronic medical records. It's a costly enterprise. So I think this is sort of a wait and see. CMS Innovation Center, there's a lot of money being poured in the CMS Innovation Center to come up with new ways to reduce the cost of care, to improve the quality, and to be able to have people who have critically chronic diseases be able to get better care and not have to go to the hospital as frequently. There are also ways, and we know this, the federal government has for years and years sort of driven goals that it wanted to achieve through the tax code. Now what we see is using federal spending and to encourage reduction in improvement in quality and reduction in costs through some payment cuts to particularly the Medicare program, but also the Medicaid program, which are the two federal programs that could be impacted. I'll mention a couple of these, and this is the quality idea. This pilot bundling is another concept similar to the accountable care organization, the ACOs that I just mentioned. Providers of hospital care, physicians, post-acute care are all paid one single payment amount, and they have to divvy up the payment amongst themselves. So the thought is that they will try to keep the patient well, or to try to, if they're hospitalized, try to improve that quality, get them back on their feet, get them out of the hospital, get them out of the post-acute care provider more quickly. Payment reduction if a patient is readmitted time and time again, and there are multiple reasons why patients are readmitted time and time again, and most times not necessarily the fault of the healthcare provider, but perhaps a lack of some either determination or family support on the perhaps of the patient. Reduction for payment for hospital-acquired conditions, something no facility wants, and sometimes they're easy solutions and sometimes they're not easy solutions. But the idea is to start to think about how quality is being provided, and this is the carrot and the stick, and this is the stick. If you don't, if you continue to have inappropriate admissions and hospital-acquired conditions, we're going to pay you less. Bending the cost curve. Well, I just learned that today the House voted to repeal this first bullet, the Independent Payment Advisory Board. I knew that it had passed out of a committee and was going to a vote today on the floor, so it's passed the House, and now we'll see what the Senate says about it. The Independent Payment Advisory Board was part of the act. This is another payment reduction method. To try to reduce the per capita cost spending, and a lot of people didn't like it because the idea was it was going to take care away from those who needed it. We'll see how that, I'm not going to go into that anymore. A tax on Cadillac plan tax is a tax on benefit plans that are very rich in terms of benefits and cost a lot, so there will be a tax on that in 2018. Also payment reductions, and these are the payment reductions. $455 billion in payment reductions over the next 10 years. Add another $11 billion in the payroll tax extension and the physician, SGR physician extender bill over the next 10 years. So a lot of cuts to healthcare providers. When that happens, and those of you who are going into healthcare will understand this more as years go on, you're asked to do better and to do more for less in terms of reimbursement. That is difficult. We're all called to do that. And so it impacts me because it means my clients don't want legal services or can't afford to pay for legal services. So we all have to, it impacts a lot of different people. Program integrity. I'm going to whiz through this, but this is probably what you read most about. How many of you heard of the HEAT program? You know, we arrested X number, fill in the blank, in Detroit or South Florida or Texas or Baton Rouge. Those are some of the sites for the HEAT program. A lot of money is being poured into the Office of the Inspector General for fighting fraud. $250 million over 6 years. That's a lot of money. Also, healthcare providers are going to be required to have compliance programs. Most that I know of, my clients have had compliance programs for 10 or more years, but now it's going to be a requirement. A provision that doesn't mean anything to you, but it means a whole lot to my clients. If there's an overpayment identified, you have to notify the CMS and or the Office of the Inspector General if necessary within 60 days, and repay. So report and repay. Suspending providers where there's a credible allegation of fraud and excluding them. So a lot of ways. So now everybody just take a sigh of relief. We are finished with reviewing the Affordable Care Act. So can you see how there's a little bit in it for everyone, something to like, something to dislike immensely. Perhaps you feel very strongly about this from a political standpoint, and I applaud you because of your strong feelings. But perhaps you feel very strongly about it, for or against it, doesn't matter. It's still an interesting time to be around. So if you'll hang on 1 second so I can turn these pages, because I have some really interesting things to say, and I don't want to leave out anything. And there's too much information for me to remember all the time, all of it. Let's talk about the cases. So, March 23rd, we have the Affordable Care Act enacted. Within hours, the Attorney General of Florida files a lawsuit. 12 states join him immediately. Ultimately, 26 states join. Another suit is filed in that particular circuit, which is the 11th Circuit, by the National Federation of Independent Business People. Those cases are consolidated. That's what happens when you have multiple cases in a jurisdiction. Do y'all understand about federal circuits? Is that something you've gone on? There are a number of federal circuits. The 11th Circuit is Florida and Georgia and Alabama. And when a case comes in a federal court, which is different from a state court, when it comes in a federal court, it starts out at a district court, and there's a trial there in that federal court. And the decision is generally appealed by the person who didn't win, who was not successful, to the circuit court. And when there is a split in the circuits, and you can see here we have 3 thumbs up, that means one opinion, and 2 thumbs down. That's an opposite. When you have splits in the circuits, that's when you get to appeal it to the Supreme Court. Got that? We have splits in the circuit. What happened, and when you have splits in the circuit, everybody files what's called a petition for certiorari. In other words, it's an appeal, but it goes to the Supreme Court of the United States, and it has a special name, and it goes to the Supreme Court. The court isn't going to hear every single appeal that's filed with it. It's going to select one, and it selected the case that came from the 11th Circuit. That circuit sits in Atlanta, Georgia. And what that court said was, and let me back up, because I needed to say something important, and I forgot to say that. There are important arguments being made by both sides. There are important fundamental principles of constitutional law that are being argued. What rights does Congress have? What rights do the states have? And those are the issues that are raised in this decision that's going to be argued next week before the Supreme Court. What the court said is the individual mandate is unconstitutional, but we can get rid of it and the remainder of the law stands. Some of the other courts and the Medicaid expansion is legal. Some of the other courts had differing opinions. So here's what the arguments are before the court. Some of this is going to make no sense to you. Some of it's going to make a lot of sense, and I'll try to explain it in as practical a way as I'm able. Here are the arguments. The Anti-Injunction Act, which is a tax law, and I'll explain it in a little bit. The individual mandate, which I've already talked about, and that's the requirement that every resident obtain these essential health benefits through some sort of insurance coverage by January 1, 2014. The severability, and we'll get to this in a minute, but if the individual mandate is held to be unconstitutional, what else does it take with it? Does it take down the whole act? Does some of it remain? Because there are a lot of good provisions. There are provisions about quality. There are provisions about increasing workforce, about having more nurse practitioners, about having more physicians trained. Does Medicaid the expansion of Medicaid go with it, or does it survive? So let's see what. Here's the Anti-Injunction Act. And when you look at it, it makes a lot of sense. This is embedded in the tax code, so think a little arcane, a little strange. But what it says is you can't file a suit to keep from assessing a tax or collecting a tax in any court. You've got to wait until the tax is paid. Then the individual that has paid the tax can say, that was a bad tax. It was incorrectly assessed. It should never have been collected, and I'm going to appeal to a court to overturn that tax and to get my money back. So you have to wait until the tax has been paid, and then you can argue that it was an incorrectly drafted tax, or it was incorrectly collected against you for some reason. So it bars pre-collection litigation, pre-assessment, pre-collection litigation over taxes. There's this weird question, though, is what's called a penalty. We're talking about the individual mandate here. And what we said is, if you don't get health insurance, you have to pay a penalty. We called it something different, though. What did we call it? A shared responsibility payment if you don't have health insurance. The question is it really a penalty or is it a tax? The way the tax code defines tax is, it's mainly to collect revenues. A penalty is something that's assessed when you violate or fail to accomplish or perform an act or a tax. So, and the reason this is important is, if the Anti-Injunction Act applies, then the Supreme Court cannot review the Affordable Care Act. It stops it dead in its tracks, and we all go home. And wait until 2014, when people fail to get health insurance and the tax is assessed, and the next year, when they file their income taxes, it's collected, and then the case can go back to the Supreme Court. But you see what will happen by then, we will have so much of the Affordable Care implemented that it could be more difficult to overturn it. On the other hand, that does give a couple of years for Congress to whittle away at the Affordable Care Act. We saw today that they voted to repeal the Independent Payment Advisory Board. The budget that Congressman Ryan has produced and proposed in the House would repeal the entire Affordable Care Act. So there's more than one way to attack, if you want to use that word, this bill, or any bill. You can attack it through the courts or through Congress. Now, neither side that's arguing before the Supreme Court wanted to argue that this act bars the Supreme Court from reviewing it. So the court had to go out and engage someone to make that argument for the court. That's what this amicus curiae is called. The court said, we need somebody to argue this point. None of the petitioners and the respondents, neither one of them, the government and the petitioners, don't want to argue that point, so we'll get someone to argue it. So the very first thing that will happen on Monday is we'll hear the Anti-Injunction Act arguments. And it'll start with this gentleman, Robert Long, who's with a law firm in D.C., and he's going to argue that the Anti-Injunction Act bars the review of the court of this act. And then the other side will argue, no, it doesn't. Okay. So, if on the court in its wisdom says, no, it's really a penalty, it's not a tax, we can go ahead and review this case. We've made that decision. Then, so if the Anti-Injunction Act doesn't apply, is the individual mandate a constitutional exercise of Congress powers? Okay, quick constitutional law lesson. The Constitution provides for certain, they're called enumerated powers. One of these huge powers is the ability to make laws based on their application to interstate commerce. And here's what the Commerce Clause says. Congress shall have the power to regulate commerce with foreign nations, so England, France, those are the tariffs that they enact, and among the several states, and with the Indian tribes. We're not, so is this a valid exercise of Congress powers? You're going to hold on 1 minute so I can turn to my page and I can say all the things that I want to say about that. Here is how the court is going to analyze this. Congress can recognize any, this is important, economic activity. We're talking about the individual mandate. Congress can regulate any economic activity that it rationally believes is in the stream of commerce, think interstate, between states, Mississippi to Alabama, or that substantially affects commerce. Economic activity that's in the stream of commerce or substantially affects commerce. Well, think about that. We have trucking companies that go back and forth. So Congress can regulate trucking companies, what they can carry, how long they can drive. You see the weigh stations going back and forth between states. Interstate commerce. The Voting Rights Act, interstate commerce. Civil Rights Act, interstate commerce. Congress relies on the Commerce Clause a lot in enacting laws. What the petitioners would say, and that would be the 26 states and the National Federation of Independent Business, they would say this is not, first of all, having insurance, they were not in the stream of commerce. These uninsureds were not in the stream of commerce. What you're doing is you're making them buy insurance, putting them in, and when they fail to, you're penalizing them. You are forcing them to get into the stream of commerce. What the government will say is, everybody uses health care. The timing of that use is unpredictable. What is important here is that there are many millions of uninsureds, and because of that, there is cost shifting. That cost shifting puts a substantial burden on interstate commerce. What it does and I've read this in one of the articles that I've read to prepare for this talk, is it costs $1,000 extra in premiums for every person who's insured to cover the cost of those who are uninsured. So we have these two positions. It's not, and the economic activity is important for us to remember. The necessary and proper clause. Well, it takes an enumerated power first. So you have this power to regulate commerce. Once you have that enumerated power, Congress can make all the laws that are necessary and proper to execute whatever it wants to do in those powers. So that's what the necessary and proper clause is. What the government will say is the individual mandate is a valid exercise, and so we have then, it's necessary and proper for us to enact all of these other provisions of the Affordable Care Act that will take care of it. What the petitioners will say is, wait a minute, the individual mandate is not constitutional. You can't bootstrap that individual mandate by the necessary and proper clause. You have to first have a constitutional use of an enumerated power. We don't have that there. So that's an argument that's ongoing. Two other arguments. The taxing power. And you're going to say, wait a minute, I thought you just told us that the Anti-Injunction Act didn't bar review because this wasn't a tax. Well, maybe it is. Here's what this is actually. This is the taxing power and the spending power. They kind of go together, tax and spend. Congress has the power to lay and collect taxes. Why does it lay and collect taxes? To pay its debts and to provide for the common welfare. Okay. Opponents claim that Congress is exceeding its congressional authority, including both the Commerce Clause and the taxing power. Here's what, however, the government says. It says that actually, for purposes of this law, the individual mandate is a practical application. This is a tax because it's collected through the tax code. It's collected by the IRS. And I'm saying, but you just told me it wasn't a tax when we argued the anti-injunction. The plaintiffs will say, it's not a tax. It's not a tax. It's an administrative penalty. We've already said it's an administrative penalty. This is confusion. So, can it be a tax for one purpose and not for another? I don't know. The other question is, are these uninsureds, is it inactivity that we're sensing with them? They're not buying. Their failure to purchase insurance, is that an activity or an inactivity? Is it non-economic activity? All of these, is it an economic decision? I'm deciding that I'm not buying insurance because I want to save my money for fill in the blank, a new house. Is that an economic decision? All of these, this is what's a little bit arcane and a little bit complicated, but it's what the court is going to be going through in its decision. And I'm going to skip this. Now, if, for example, the court finds the Anti-Injunction Act doesn't apply, we can review the case. But we think the individual mandate is unconstitutional. Then what happens? Is all of the statute unconstitutional? Are only portions of the statute unconstitutional? None of the parties have argued that the balance of the law is absolutely severable, so that the only thing that falls is the individual mandate. None of the parties have argued that. So the court had to appoint somebody to make that argument. But none of them said. And here's what they've said. Actually, I'm going to go here. Here's what the parties have argued. The states in the NFIB, National Federation of Independent Business, argue that the mandate's not severable from it all falls. They want to eliminate and to reject the entire statute. The insurance plans, you can see it's important for the insurance plans that everybody has insurance and pays a little bit into the pot. And that's the only way that it can continue the community rating and the guaranteed issue. What the insurance plans say is without the individual mandate, without that requirement that everybody have health insurance, guaranteed issue goes, pre-existing conditions go, health status discrimination goes, community rating provisions go. So all of those insurance reforms that we talked about that are so important, that keep people who have some incredible illness from getting insurance now. All those children who have cancer who can't get insurance, that will fall if, according to Blue Cross and Blue Shield Association and the insurance plans. Even the United States argues if the individual mandate is deemed to be unconstitutional, you're right. Guaranteed issue and community rating fall. We won't be able to have that. But the rest of it should remain. And here's why, and I have a slide on this somewhere. Or maybe I don't have a slide. Here's why, and I'll just tell you about it. There are 10 titles. Titles are like topics, and lots of laws underneath those in the Affordable Care Act. The first title is the individual mandate. The second title is Medicaid expansion. And let me read you the titles of the others, because these are important provisions. Improving the quality and efficiency of health care. Prevention of chronic disease and improving public health. Healthcare workforce. Transparency and program integrity. Improving access to innovative medical therapies. The Class Act, unfortunately, that's gone. Can't afford it. Revenue provisions. Strengthening quality, affordable health care for all Americans. And the employer mandate, which isn't even being argued whether that's constitutional or not. So there's a middle ground somewhere there, and I'm not quite sure what it is, but that's the way the arguments. The states are saying if the mandate falls, the whole thing goes. The insurance plans say if the mandate falls, those 4 really important insurance reforms go. Even the government says if the mandate falls, community rating, guaranteed issue go. We'll see. Medicaid expansion. This is a wild card issue because no judge has found that the Medicaid expansion is not constitutional. The importance of this is more people are brought into some sort of insurance coverage through the Medicaid expansion, 16 million, than are by the individual mandate. That's good news and bad news. It's good news for people who have coverage. On the other hand, Medicaid pays very, very little to healthcare providers for their services. So it's going to mean they're going to have more patients and they're going to get paid less. On the other hand, perhaps they get paid something, and so it's not, those services don't go to bad debt. Here are the arguments, and this is called a coercion argument. I think this is interesting. I get into this argument. What the administration says is, look, Medicaid's a voluntary program. States don't have to have Medicaid. And besides, Congress can tell recipients of money what they have to do. You know, you don't get money unless there's strings attached. There's strings attached. And we're telling them. And besides, this saves you money. States, it saves you money. The states say, wait a minute, the individual mandate's tied to Medicaid expansion. It's this whole idea of getting more people on insurance and access to care. Congress didn't provide a Plan B to states who decided they didn't want to expand. I mean, it's expand or lose your Medicaid funding. It provided a Plan B for exchanges. The Plan B for exchanges is if a state doesn't want to or can't set up an exchange by 2014, the federal government will come in and operate it. And they say the sheer size of the transfer payments and the sheer size of the money coming in to pay for the expanded coverage is enough for states to, it's coercive. They have no choice. They have to accept this and expand. So the question is there some outer limit, some line in the sand that says this is what Congress can spend? And can Congress really set terms of behavior, what you have to do in order to receive that money? Well, my mother always set terms when she gave me an allowance. If I didn't do my chores, I wasn't going to get a term. So I kind of understand the federal government's not going to give me any money unless it sets, which is a reason not to do business with the federal government, but that's another issue. So here's my decision tree that I'm not going to go, but you've seen these on, you know, if such and such happens, go to step B. You filled out those applications before. This is a decision tree. I'm about to get into some fun stuff. They'll just hang in there with me. Here's what's fun. There's been a lot of paper, a lot of trees killed with these briefs that have been filed. There are 20 merits briefs. That means briefs that are filed by the parties that are participating in the arguments and that file petitions for certiorari on the merits of the case. But these amici, these are friends of the court. That's what that means. Amicus curiae means friends of the court, have filed over 100 briefs. So I just pity the poor clerks for these justices, non-justices of the Supreme Court, who have to read all these briefs and write memos and then to the justices. I gave you some information. There is a world, just Google, everybody has a computer, Google health reform, and you'll pull up Washington Post, New York Times, a gazillion blogs. If you go to the American Health Lawyers, and I've left some materials out on the back, it's an organization of which I'm very fond, but there's a blog. You can add your comments, and it will be noted, and you'll see a lot of other writings there on that blog, all of these other blogs that you can talk about. Now I want to talk about the people that are involved, because I think that makes it more interesting. I think it's interesting that although this is not going to be televised, there are 3 days of arguments. They start on Monday. The arguments are in the morning. By 4 o'clock in the afternoon, you can go to the Supreme Court's website and you can listen to the arguments. I think that's wonderful. Now, you may not be a real healthcare wonk and want to listen to all these arguments, and you may not, but the very fact that we have that opportunity to do that, I think is a terrific example for our democracy. I want to tell you a little bit about the men, emphasis, no women, men who are arguing at the Supreme Court. I don't know why they didn't have a woman arguing at the Supreme Court, but that's because she's on the Supreme Court now. The first day, and we noted, here's the amicus, nobody else voted, parties that filed petitions did not believe that the Anti-Injunction Act should bar the review. So the court put someone in. It's Robert Long. He gets 40 minutes. The Solicitor General, I'm going to tell you a little bit about him, is Donald Verrilli. He became Solicitor General when Justice Kagan came on the Supreme Court. She's a little short lady that you recall being confirmed. I'm going to tell you a little bit about him. He is a top appellate lawyer. He has argued 17 cases before the Supreme Court. Now, there are not many people who argue before the Supreme Court. There are several in Mississippi. One of mine was a law professor. Professor Cochran argued a number of cases before the Supreme Court. There's what's called a Supreme Court bar, and it's not where you get drinks. It's the group of lawyers that argues at the Supreme Court. And they're very collegial and probably very snooty, but maybe not. But they have their little sort of college of Supreme Court lawyers. He went to Yale undergrad and to Columbia Law School. He clerked for Justice William Brennan. Now, regardless of your political persuasion, Justice William Brennan was one heck of a justice, and he wrote beautiful opinions. He's no longer there. He used to work for a law firm, Jenner & Block, and he argued First Amendment cases and communications cases. Theodore Olson, who was President Bush's first Solicitor General, said of him, "I'm a big fan of Don Verrilli. He's a superb lawyer and a perfect gentleman." I don't think there's going to be a lot of shouting at the Supreme Court. I think this is going to be a very civilized. But he notes that he is competitive and he's in it to win it. So we'll see how he argues, and I'm interested to hear his voice. The states and the NFIB are represented by Paul Clement, emphasis on the last syllable, and Michael Carbon. Paul Clement is a really interesting person. I'd like to meet him. He's 45. He's a Republican. He's a former Solicitor General. That's the top lawyer for the Justice Department who argues the cases before the Supreme Court. Ken Starr. Do y'all remember Ken Starr? President Clinton's. Okay. said he's the best advocate of his generation. He argues his cases at the Supreme Court with no notes, 0 notes. He says it's important to listen to what the justices are saying, and he likes to make eye contact with them. And his tone is very conversational. They said he has a Midwestern earnest tone. Can't wait to hear that. He went to Georgetown, undergrad to Harvard Law. He teaches as an adjunct professor. Did I say he's argued 57 cases before the Supreme Court? Good grief. He clerked with one of the current justices, Justice Antonin Scalia. And they used to have rousing arguments. And he rides his bike 35 minutes to the office every day. He lives in Alexandria. So he's a health nut. He's 45. He has a wife and children. He teaches. He works. When his law firm, before he went to Bancroft, told him he couldn't take a case, he quit. It's a wonderful law firm, King & Spalding. He quit and went to this smaller firm. He's a man of principle. So, I mean, what's not to admire about him? The other person I want to talk about a little bit is the Chief Justice, John Roberts. This is going to be a major case for him. This will define his legacy. It's not very often that a case like this comes along, that such a substantial piece of legislation that has such an economic impact on the country. He has been in the majority of 90% of the cases that are decided in his court. He likes to be in the majority. You know why?
He gets to pick who writes the opinion.
That's right. He always gets to pick, and if he's in the majority, he gets to write the opinion. So where do you think he's going to be on this case? I'm guessing he's going to be in the majority. I'm not sure what it's going to be. I don't know what the ruling's going to be, but I'm guessing he's going to be in the majority. He has 2 instincts, I've read. There are, if you go and Google him in Washington Post, you're going to pick up articles about all of these men that I think is very interesting. He's a steward of the court's prestige and authority. It's very important to him that the court be considered highly independent, not prone to politics. He likes incremental decisions from large majorities versus broad but sharply divided decisions. But he's embraced many judicial projects that are controversial for some. He's cut back on campaign spending limits. He's opposed gun control laws. He's reduced procedural protections for criminal defendants. In 2010, he sided with 4 more liberal members that affirmed Congress' power to continue to confine sex offenders after their criminal terms had been completed. He was wrote the opinion for Citizens United. That's the decision that has loosened the controls on campaign spending. And there was a huge firestorm after that ruling, and those who write about the ruling say that he was surprised about the reaction across the country to that ruling. So I'm just wondering if that's going to be in the back of his mind when he's thinking about this decision. Going on through, the individual mandate is argued on Tuesday, 2 hours. On Wednesday, severability and Medicaid expansion are argued. So 3 days, 6 hours. This is the first time since the Voting Rights Act that there has been this long of a time allowed for oral arguments. For Bush v. Gore, the lawyers got 90 minutes. So sort of weigh that. After the arguments are finished, this is very civilized, the justices gather for a private conference and they cast a tentative vote. as soon as the arguments are finished. If Roberts is in the majority, he will choose who writes the majority opinion. So, to tell you that I'm just a little bit excited about next week is an understatement. I'm going to be at a Medicare and Medicaid Institute, which is a conference of health lawyers for 3 days talking about Medicare and Medicaid payment. And in the afternoon, we're going to have a special room on Wednesday, and then I'll be there on Tuesday afternoon and can listen in. So I applaud you for coming tonight, because I think it means, in addition to maybe you got credit for your course for coming here, that this is somewhat interesting to you. I encourage you to Google it and read the articles written. Google and read Politico, or maybe not Politico, because it's going to be political, but read a broad variety so you get a balance of opinions, because this is a political issue. And not only is this a huge case, but it's in an election year. So, and it's going to impact what Congress does from now on out. So it's a very exciting time. That is the end of my slides. I know you're all probably happy, and now you can relax a little bit, but I will take questions, and if I can answer them, I will, and if I can, I'll find the answer. You've been a great audience. I mean, I haven't really seen many people asleep, which so that's all comes up.